Hi and welcome to people joining. We're just going to give people a couple of minutes to make sure that everybody is able to catch the beginning of the talk. So thanks for your patience while you wait for us to join. Welcome to everybody who is joining us today for the November VAMHN lunchtime webinar. I'm absolutely delighted to be joined by two colleagues from City St George's, Annie and Estela, who will be talking today about the health outcomes of victim survivors accessing specialist domestic abuse services, the role of abuse experience, vulnerabilities and sociodemographic characteristics. I'll hand over to Annie in just a couple of minutes, but just to do a little bit of housekeeping first. We run these as webinar sessions rather than as meetings, and that means that, as you'll have noticed by now, you are muted and cameras off. That means that although we have a Q&A session at the end, you won't be able to ask the question directly to Annie and Estela. So what I will ask you to do, please, is to use the Q&A function. If you could submit your questions through the Q&A box, I'll then moderate those and I'll put as many of them to Annie and Estela as I can. If you could use, please, the chat function for introductions and any resources that you would like to share with others on the webinar today. We do find that people attending the webinars have such a wealth of expertise and knowledge that there's invariably papers, projects, statistics, contacts to be made that benefit everybody. So please do use the chat function to do that. Annie's bio will be appearing in that chat in the next few seconds. Please don't use the chat to put questions in. It is almost impossible for me to keep track of the chat function and the Q&A at the same time. So if you put your question in the chat, I'm likely to miss it. Just to reassure you that we are recording the webinar today. And we will send the recording and we will send a copy of the slides to everybody who has registered for the webinar today. So you will receive those in due course. Also, just to make you aware that this we run monthly events. We actually have two events happening in December due to a rescheduled event that was due to be in October from Dr. Claire Powell and Karen Johns. So if you missed that and you want to come in December, please do sign up at Eventbrite. We also have a further webinar happening in December from our colleague Adeline from Birkbeck, who will be talking about child sexual abuse. So two really good talks coming up over the next month. I don't want to delay today's talk any further, so with huge thanks, I'm going to hand over to Dr. Annie Bunce. Thank you.
Thanks, Sian, and thanks everyone for joining us this morning. So as Sian said, today I'm going to be presenting some work that I've completed alongside Estela, who's here today, and also Eloise Davies, which was co-produced with stakeholders from Women's Aid, who we've been working with now for the past 4 years. And the paper examines the role of abuse experience, vulnerability and sociodemographic characteristics in the inequity of health outcomes for survivors of domestic abuse. Just to say, there is a preprint that's already available online, but the paper has since been through 2 rounds of quite comprehensive revisions and is currently in the final stages of peer review. So it should be available in its most best form very soon as part of an edited collection in BMC Women's Health. So just to thank our funders, the UK Prevention Research Partnership, for enabling us to do this work. And I have actually, in the interest of time and telling people too much about things they already know, I have not got a literature or background slide today. I think I can sort of assume that most of us are aware of the links between domestic abuse and health, the issues of identification and referral, and the need for support services. We do have a really comprehensive literature review in the paper, so please do refer to that if you're interested in looking at the literature in detail. So the primary aim of this study was to explore the relationships between victim survivors' experience of abuse, any additional needs or vulnerabilities they have, and their sociodemographic characteristics, and their health outcomes following domestic abuse. So to achieve this aim, we had 3 research questions. Firstly, which factors are associated with the physical health outcomes of victim survivors accessing specialist domestic abuse services? Secondly, which factors are associated with their mental health outcomes? And lastly, which factors are associated with their healthcare seeking behaviour? So in terms of the data that this analysis is based on, data was provided to us by Women's Aid, who are a federation of over 170 domestic abuse services, providing around 300 local services to women and children across England, and our research partners for this work. The data for the study was originally collected by Women's Aid's case management and outcomes measurement system called On Track, which provides the largest national data set on domestic abuse in England. And data are inputted to On Track by frontline staff on a day-to-day basis as part of their daily work. The data we analysed spans the period from April 2016 up until March 2023, and specifically the data that we analysed for this paper came from 2 data sets, one containing demographic information and information relating to victim survivors' support needs, and the other information about the nature of the abuse that they'd experienced. We identified and kept only those variables that were of interest for our models, and then merged these 2 reduced data sets together to do our analysis. So in terms of measurement, our 6 outcome variables we've grouped into 3 concepts. So the 2 variables that we looked at under physical health outcomes were attempted or non-fatal strangulation, and the perpetrator having caused harm to or loss of the victim survivor's unborn child. In terms of mental health outcomes, we looked at disclosed self-harm and feeling depressed or suicidal. And in terms of access to health services, we had 2 variables: abuse resulting in injury requiring GP treatment and requiring A&E treatment. And our 3 key independent variables were needs or vulnerabilities of victim survivors, which included offending drug or alcohol support needs, disability, pregnancy, recourse to public funds, by and for, and perpetrators living at the same address. We looked at multiple abuse types, including emotional, financial, technology facilitated, and threats to kill, and also the role of sociodemographic characteristics, including the type of accommodation, sexuality, ethnicity, gender, and age. And just to clarify a couple of these variables in case not everyone is familiar, recourse to public funds indicates whether the victim survivor is eligible to claim UK state benefits, housing support, and tax credits. And by and for services are services run by and for the people they serve. So for example, Black and ethnic minority women or LGBTQ+ survivors. And the variable perpetrator living at same address measured whether the victim survivor was cohabiting or living at the same address as the perpetrator, either all the time or intermittently. So to understand which factors are associated with victim survivors' health and health-seeking outcomes, we ran a series of multivariate logistic regression models, which basically model how shifts in predictors alter the odds of various categories occurring. Our models controlled for potentially confounding variables identified from existing literature, and so our results are reported as adjusted odds ratios, which essentially shows us how a predictor variable affects the odds of an event occurring after adjusting for the effect of the other predictor variables. So altogether, our merged data set contained just under 189,000 observations, but we kept only cases with complete data, so that means no missing data on any of the variables in the model. And that gave us just over 77,000 cases that were actually included in the analysis. In terms of descriptive, 96% of victim survivors accessing domestic abuse services were female, over 3/4 were white, and the mean age was 40. Almost half reported having felt depressed or suicidal, and over 20% had experienced attempted strangulation. So in terms of our findings, there were lots and lots of them. So I'm not going to report all of the effects today. I've just picked a select few which we found particularly interesting. So in terms of the physical health outcomes of victim survivors, when it came to attempted strangulation, those who'd experienced threats to kill were 4 times more likely to have been strangled by the perpetrator. Those with offending and alcohol support needs were also more likely to have been strangled, and as were gay victim survivors, and females were more than twice as likely than men to have suffered attempted strangulation. When it came to harm to or loss of unborn child, victim survivors who were Black, those with a disability, those with offending support needs, and those living in refuge or shelter were all more likely to have experienced harm to their unborn baby. So moving on to mental health outcomes, there was lots of associations here. In terms of self-harm, experience of all abuse types increased the likelihood of victim survivors having self-harmed, with tech abuse, sexual abuse, and financial abuse particularly strongly associated. Similarly, all needs and vulnerabilities increased the likelihood of self-harm, except being pregnant, which was non-significant, and particularly having a disability and having an alcohol support need, which both more than doubled the odds of having self-harmed. Those in student housing or refuge were twice as likely to have self-harmed, and those in care were almost 4 times as likely to have self-harmed. So in terms of feeling depressed or suicidal, quite similarly to self-harm, experience of all abuse types increased the likelihood of this outcome, with this time tech abuse, emotional abuse, and threats to kill the ones particularly strongly associated. Pregnant women were slightly less likely to have felt depressed or suicidal, and those accessing by and for services were far less likely to have felt depressed or suicidal than those who weren't accessing these type of services. Those who lived in social housing, temporary housing, or refuge were all more likely to have felt depressed or suicidal than homeowners. So finally, when it came to healthcare help-seeking outcomes, those with no recourse to public funds were significantly less likely to seek help from their GP. Those living in social housing, temporary housing, or in care were all more likely to seek help from a GP and A&E, and this was also the case for victim survivors living in refuge or shelter. Those of Asian ethnicity were significantly less likely to visit A&E, but there were no significant differences by ethnicity in terms of visits to the GP. And when it came to gender, females were more likely than men to seek help from their GP, but there were no gender differences in visits to A&E. And lastly, those who'd experienced sexual abuse, tech abuse, and threats to kill were all more likely to visit both the GP and A&E. So overall, associations with the type of abuse experience varied by health outcome. For example, physical abuse followed by threats to kill were most strongly associated with attempted strangulation and injuries requiring GP and A&E treatment, whilst tech abuse was most strongly associated with self-harm and feeling depressed or suicidal. Vulnerabilities and additional needs showed more consistent associations, exacerbating the negative health consequences of victim survivors across all 3 groups of outcomes, but particularly mental health, with disability increasing the odds of both self-harm and depression twofold, drug and alcohol needs and the perpetrator living at the address increasing the odds of both, offending needs increasing the odds of depression, and having no recourse to public funds increasing the likelihood of self-harm. That we found poorer physical and mental health outcomes and higher likelihood of seeing health services among those with a disability is supported by existing systematic review evidence, and could be because barriers to care often faced by women with physical and mental disabilities may be overridden by immediate treatment needs which catalyse health service use, especially for those who are pregnant who may seek healthcare help out of concern for their baby's health over their own health and well-being. Different results by ethnicity across all groups of outcomes demonstrates the compounding vulnerabilities faced by minoritized ethnic groups. These findings echo existing work which has highlighted the so-called complex needs of women accessing domestic abuse services and the value of by and for services for Black and minoritized women experiencing domestic abuse and mental ill health. Although the findings on the effect of by and for services does need to be considered carefully due to the relatively low number of by and for services that were in our data. It's also important to bear in mind that the current analysis was based on a sample of victim survivors who successfully accessed support, and some marginalised groups, including Black and ethnic minoritized women, those with insecure migration status, and those with no recourse to public funds, we know are less likely to be able to access support and may also be less likely to disclose abuse in the first place. Furthermore, we also know that intersecting inequalities compound barriers to disclosure and help seeking. So any findings in relation to ethnicity should be considered in light of structural inequalities and their effect on barriers to accessing services. Our findings on the high risk of strangulation associated with threats to kill on the one hand, but not emotional abuse, make a valuable contribution to the relatively limited evidence base on non-fatal strangulation. Taken together, these results are indicative of a tipping point from emotional abuse to threats to kill, which then escalates to attempted strangulation. These results should also be considered within the broader context of coercive control, a systematic pattern of behaviour that establishes dominance over another person, often including through threats of violence. Abuse in any form was unequivocally associated with adverse mental health outcomes, and that the strongest associations were with tech abuse and sexual abuse supports previous findings on the devastating impacts of these forms of abuse. Those who'd experienced these two types of abuse were also more likely to go to the GP and A&E, although only slightly more likely for those who'd experienced sexual abuse, which could be reflective of ongoing stigma. Our findings also highlight the intersection between domestic abuse and economic or housing instability and poor health outcomes, with those in refuge, in care, and living in social housing, temporary or student housing, generally experiencing poorer outcomes. For those seeking refuge, they may have been in particularly severely abusive relationships with high risk to both themselves and their baby, and this could have catalysed fleeing their home in order to protect their baby and seeking help from healthcare professionals. Findings on student housing, tech, and sexual abuse and poor mental health could reflect a lack of support for or even a culture conducive to these types of harmful behaviours amongst young people in educational settings, or the challenges experienced by schools and the specialist support sector to keep up with the changing dynamics of tech abuse. Interestingly, being in student housing wasn't associated with feelings of depression or suicide, but was with self-harm, suggesting students are at heightened risk of self-harm despite being less likely to report feelings of depression or suicidality. There could be several reasons for this finding, such as disclosure reluctance, which could be related to negative school cultures, or perhaps that students don't disclose that they're struggling with negative thoughts until they harm themselves, or that self-harm in this context may be a cry for help as opposed to a direct result of feeling depressed or suicidal. So the current study has two considerable strengths. Firstly, that our analysis is based on a large national data set from a federation specialist domestic abuse service. This type of administrative data is rarely available to researchers, so our study extends the existing evidence base on health outcomes and healthcare utilisation of victim survivors, within which most studies are small samples from clinical trials or small observational studies. Secondly, the study was co-produced with stakeholders from Women's Aid, whose input we were lucky to have from the point of developing research questions to the interpretation of our results. This provided valuable insights in terms of frontline service delivery and data collection and recording practices, and victim survivors' pathways between abuse and health. As with any study, there are also notable limitations. So first and foremost, we didn't gather insights from victim survivors themselves, which would have enhanced the depth of our perspective. Secondly, the data analysed pertains to a population who had successfully accessed domestic abuse services, which means the characteristics and experiences of those not disclosing domestic abuse and not in receipt of any support, who we know are likely to be those with the highest need, aren't considered in our analysis. Another key limitation of this study is the exclusion of just over half of cases due to missing data. While this reduces generalizability and may have excluded individuals with more complex types of abuse and vulnerabilities, the decision to conduct a complete case analysis was made because the missing data wasn't missing at random. By that, I mean that individuals with incomplete records had different health and health service outcomes, which could have skewed our results. So this approach prioritized internal validity and interpretability while recognizing the trade-off in representativeness. Finally, as is a common limitation of studies in this area, it's not possible from our analysis to establish causal links in any direction between abuse needs and vulnerabilities and health outcomes. Particularly when it comes to mental health, the few studies that have tested causality show that it can work both ways. So pre-existing poor mental health can increase people's risk of subsequent domestic abuse victimization, and experiences of abuse can have adverse consequences on mental health. Findings from the rich qualitative literature on domestic abuse suggest the direction of the relationship, for example, describing a turning point where women realize the impact of the abuse. While there is scientific value in employing robust causation designs to better understand the relationship between domestic abuse and mental health, there are also moral and ethical implications of doing this, and often, as was the case for us, the data available doesn't enable this type of analysis. Regardless, we feel our study has contributed to the ever-growing literature which supports the negative impact of domestic abuse on victim survivors' health. So moving on to some implications of our findings, threats to kill increase the risk of non-fatal strangulation fourfold, and those who'd experienced these were over twice as likely to visit both the GP and A&E, and this represents a critical opportunity to intervene before threats become fatalities. Training is needed here to better equip healthcare providers to spot the signs of and risks associated with non-physical forms of abuse, particularly threats to kill and tech abuse. Research practitioner collaborations, combined expertise and cross-training between multiple agencies, tailored interventions for perpetrators of non-fatal strangulation, and interventions to support and empower victim survivors to leave perpetrators of coercive control before violence escalates are all key to the response that's needed. And as we have reinforced in every paper we've published over the past 4 years, there's a need for increased funding and availability of specialist by and for domestic abuse services and specialist mental health workers. We also show there's a need for greater socioeconomic security for victims of domestic abuse, including safe and stable housing. Consideration must also be given to those in student housing, who our study found to be at greater risk of adverse mental health outcomes, but less likely to seek healthcare help. Policies must be directed at protecting victim survivors. Secure funding streams must be put in place to address their long-term social and economic needs. And intervention should focus on women's autonomy and agency and provide flexible services tailored to their needs. While we're seeing positive movements in these areas, there is still a need for deeper understanding of the intersection between domestic abuse, socioeconomic vulnerability, and health, and how to apply this knowledge to the development of more holistic, coordinated, and effective responses to these and other co-occurring problems. Alongside much-needed specialist service provision, statutory services must also be culturally appropriate and trauma-informed to be able to meet the needs of specific groups and make appropriate referrals. And finally, but definitely not least importantly, building lived experience perspectives into research from start to finish is also critical for gaining a fuller understanding of experiences of domestic abuse and its impact upon health. So to conclude, we have demonstrated the devastating outcomes associated with experiencing many different types of domestic abuse and having additional needs and vulnerabilities in terms of victim survivors' physical and mental health and healthcare help-seeking behaviour. Critically, our findings highlight the almost inevitable harms to mental health for victim survivors of domestic abuse, the dangers of non-physical types of abuse such as threats to kill and tech abuse, and the very real risk of attempted strangulation. Health professionals, specialist support workers, researchers, and policymakers must continue to explore more joined-up ways of working to further improve the response to domestic abuse and intervene before irreversible damage is done. Given that suicide has been identified as the most common cause of death for victims of domestic abuse for the second year running, the need has never been greater than it is now. Thank you everyone for listening. I hope that's been a relatively helpful overview of the study, and keep an eye out for the published paper soon. Thank you.
Thank you, Annie, so much for sharing those findings with us today. One of the things that we really aim to do through this webinar series is to bring the latest evidence from across the sector to our members, and that's a really good example today of findings that are almost in press but not widely available at the moment. And so it's really great to be able to get those out to our membership, really recognising the long period of time that findings can spend going through the peer review process. So thank you. I mean, such really stark findings in there, and lots of findings in there that we could discuss. If people do have questions that they would like to put to Annie and to Estela, we have around 15 to 20 minutes to discuss those findings in more detail, so do put those through. One of the findings that came through very strongly was, as Annie mentioned in the closing slides there, about the risk of self-harm and attempted suicide. We did have one of our webinars in earlier in the year was from Tim Woodhouse, who was talking through his findings on the links between domestic abuse and suicide. So if you haven't already watched that one, the recording of that is available on the website, and so that's a very good one to follow up on. So Annie, one of the things that you mentioned was that the benefits of doing this research with obviously there's pros and cons of using administrative data, but one of the real advantages here is that you were able to look at these questions in relation to a help-seeking population, a population of women who were seeking help from specialist services. I wondered whether you could just say briefly, are these findings broadly consistent with what you do see in general population data, or are they more extreme?
That's a very good question. Estela?
Sorry, I was just struggling to unmute. Do you mean as in are the findings of domestic abuse, is the type of health seeking different between people who experience domestic abuse and the general population, and the health outcomes? Is that your question?
Yeah, I'm wondering whether the types of associations that you see and the magnitude of those associations are they similar? Are they more pronounced for this sample?
They will be, yeah, they are more pronounced in the sample. So the frequency of self-harm is much higher in this cohort than it would be in the general population, but also help-seeking behavior is different. So these people also, go to A&E more often, go to the GP more often, require healthcare more often. And I think what was for us kind of not surprising, but in a way the magnitude of need in relation to attempted strangulation, that it is so much more common in this cohort than in the general population. Yeah. So that would be, so definitely all the outcomes were looked at, so all the physical, mental health, but also all the help seeking behavior outcomes are much more pronounced in this cohort than they would be in the general population.
Yeah. So really important to be doing this research with this data set and being able to get those findings into circulation. So the threats to kill and the escalation to attempted strangulation and the prevalence of attempted strangulation was really extraordinarily high. And I wonder if you could say a little bit about what do you want services to do in response to those findings, and you can interpret services as being as wide as you like, lots of agencies who this would be relevant to.
I think I guess it's a bit more sensitivity to the signs that, I can't think of a better way of wording this, but that might not be immediately obvious, because we think of attempted strangulation as something that's really physical, and actually sometimes there's no visible, or a lot of the time there's no visible injury. And also often people will go to A&E or the GP because they really need help, but it's not necessarily for something that is physical that they are visiting health services for. And I think there has been definitely progress in this area, but I think there is still a tendency to look at things as physical or not physical, and actually oftentimes it's kind of a combination of the two. So yeah, I think it's just being more aware, not just of the signs initially, but then of, particularly with the threats to kill, how often these are, and then how easily they can escalate into attempted strangulation, which we then also know has links to domestic homicide and intimate partner homicide. So, you know, there's potentially a quite, you know, opportunist time there to intervene. And so, yeah, I think it would just be almost hyper awareness of that.
And perhaps, John, also taking that it is a tipping point when someone, you know, receives a threat to kill. And I think when we were designing our study, we thought this could be an outcome in its own right, because, you know, it is a health related outcome, but because it really links to the other outcomes in such a strong way, we thought actually we want it to be an action, because therefore it's an action by someone who threatened someone else, as opposed to so then there's kind of the power dynamics of it, and then you attributing, you know, the action to the right person as opposed to putting it on the receiving person, which is the victim survivor. And so it's kind of for services also to not minimize that when someone is threatened to kill, that is actually a tipping point in the relationship, and there's something around then putting protections in place so that it doesn't actually escalate to homicide, which we also know from the literature is something that is very frequent as a result.
Thank you. I'm just scanning the questions that are coming through in the Q&A. A question saying you mentioned the need to collaborate between research and practice, and I was wondering what changes you have been seeing in recognizing this, if any, as in what is currently being implemented.
That's a really interesting question, and we actually have a workshop scheduled in a couple of months' time with our stakeholders to basically to get their feedback on exactly that. I think, I mean, for us, obviously, something that we find out about is we know that there's been changes to data recording and practices. So, you know, and ultimately we can't kind of do anything about this unless we know the magnitude of the problem. So I think we'd probably be confident in saying that by specialist services, this type of harm is being recorded better already. And obviously that just needs to be something that catches on across the board. But in terms of practice, like for actual service delivery, Estela, have you got any?
I think I'm going to kind of reflect a little bit on our journey as researchers. So we started collaborating with the specialist support services and with research and evaluation teams in the beginning. And I think even our practice has changed over time. We began doing more like peer research. We began involving people with lived experience differently. And I think that is kind of reflective of where we're going with research. So when we wrote the grant vision, which was in 2020, which now feels like a long time ago, the practice in collaboration and what we did and what we call PPIE, which is, you know, public and for our healthcare kind of patient involvement and engagement, that has massively shifted. And I think as researchers, Annie and I also have shifted our practices. So also while we have always worked on like a collaborative and workshop based type of approach, the people involved in it have changed over time, and also how we approach the research has changed over time. And I think any research is kind of bettered if we do it in collaboration with the people that are mostly affected by it, because there is kind of no go in producing science for the science sake itself. Like, it's, you know, science should be produced for benefit of a wider population, and we have learned methodologically to do it differently in the past 5 years. I think that's my answer.
Thank you. A further question coming through in terms of the sample composition. So what were the numbers or proportion of the sample in student housing? What were there's a few different queries within this. What was the proportion of participants in student housing? What were the different categories of housing? And was that housing at the moment of seeking help from services?
So Annie's going to look up some numbers, but I will respond the general. So yes, it is recorded at the point of seeking help, but it is true that people appear in the data set multiple times. So therefore they can change their housing category as they go. So it's, if they received more than one service, then it's kind of at the entry point for that specific service. And a little bit like hospital spells, some people receive multiple services, some people come in and out, and some people actually will stay in but have different points of contact with services, and then housing is recorded at that level at the point of contact. So there are that people do change, because that's one of the questions. But the thing that I think is important is, as always, people in student housing is a very small proportion, and that's just because that is true that the general population is not in student housing, but it's also because this is kind of quite an underrepresentative type of population, to the point that, for example, the crime survey for England and Wales has no one in student housing, because that's not considered household. So we do have some, and Annie, if you're able to say how much it is, though a small, so although the finding is kind of significant, it is a small proportion of people in there.
Yeah, it's less than 1%. And sorry, I think was the other question, Sean, what the categories were?
Different types of housing, yeah.
So we had other or temporary housing, in care, healthcare system, social housing, military accommodation, private sector, rough sleeper, refuge or shelter, and student accommodation. And yeah, that was it.
Okay. It was quite granular, actually, so quite a lot of different categories.
Yeah.
Thank you. And there was a kind of further question within that, Estela, which I think you've answered. So do you have evidence of changes in housing for an individual over time? I think from your answer, you do have that, although perhaps this hasn't been the focus of this analysis to look at how that would work through. Was there anything in the data that showed victim survivors in experiencing encouragement to harm themselves, including taking their own lives? Is that something that would be captured in this data set, or is it something that you plan to explore in discussing this further?
I don't think we have a variable that measures that directly in the data set, although this is something that we might want to actually go back to Women's Aid and ask them. So I don't think that the healthcare impact variables in the data set, they are impact of their experience of domestic abuse, but there is nothing that says as prompted by X, Z, and Y.
Yeah. Okay. And a question, was post-separation abuse included as one of the types of domestic abuse?
Indirectly, because so not as, you know, this is pre and this is post separation. We do know whether they live together or they don't live together, and again, we do know if it changed in the process of receiving support. So we don't have a variable that says actually this is post separation abuse or this is pre separation abuse, but because we know whether they live together or don't live together and when that happened, it's indirect. And it's also, I think, kind of for us to bear in mind is that our analysis does not have time as a variable. So we're not looking at, if you want, the trajectory and the time span. We have another paper where we've done some of that, where we have then kind of time as an important component of it, but not this one on health outcomes.
Thank you. Going back to the question on the strangulation findings, you mentioned, Danny, that the strangulation literature is really limited, and so this was an important contribution to that. I wonder what is your kind of next question that you want to answer to bolster that literature on the impacts of either the prevalence or the impacts of attempted strangulation?
That's a really good question, and actually a really nice question, but I do feel like it's one I'd have to think about a bit. Sure. But thank you. Estela might have an idea. She thinks quicker than I do.
I think, and I don't know if it's kind of Annie and I or vision more broadly, is so attempted strangulation has also been kind of highlighted by the Domestic Abuse Commissioner as an important health outcome to look at, and there's been some stuff around the NHS not being able to identify non-fatal strangulation properly and not treated properly. So I think there's something around us thinking of kind of what happens, and it might involve kind of work with our colleagues that look at homicide reviews, and other types of kind of statutory reviews, because they might be uh, um, places where we can get some more insight of what the impact is. Also, it would be interesting to have conversations with services themselves, whether there's
Yeah.
something else we need to record on the data
Yeah.
set to be able to better capture the impact of non-fatal strangulation, which we currently don't have. I think that's an obvious one for us to take forward.
I think as well, actually, now that I've had a few seconds to think about it, I think some qualitative work on that with victim survivors would be, I mean, obviously that would be a really sensitive study to conduct, so you'd have to think about the way that you did it, but I think that would be a kind of useful approach in combination with some of the things that Estela mentioned.
Thank you. And I suppose another kind of a sort of bigger question as we're kind of moving towards the end of a time today together. We've talked about how vulnerability exacerbates negative health consequences, and I wonder if you could just talk a little bit more about what do we need to do in response to that finding and the findings of the intersecting vulnerabilities and cumulative vulnerabilities that people experience. So what do we need to be doing in response to that? And I suppose, to what extent do you feel like we are getting that right? Where do we need to be doing things differently or better?
You want me to take that, Annie, a more general response? So I think we need to understand, what we mean by culturally appropriate, what we mean by trauma-informed. We know we often talk about the trauma-informed care principles, but I am not convinced we actually do it that well, even within our own teams. So I think there's something around even understanding vulnerabilities and what the intersections of vulnerabilities are. And what does it mean that we have to, so there's something about we should understand the services that each individual will come with their own, attributes or characteristics, and that we do need to tailor our response slightly, because people are not the same. What they understand of their experiences is not the same. What they understand of their vulnerability is not the same. Some people may be, like me, gay, and not feel this is a particular vulnerability, whereas others might feel it as a vulnerability. So there's something around us responding in a more, and I know this is difficult because everyone is working so much and so hard, and then we have to follow our own company's kind of principles and policies and whatnot. But I think that there is something around us understanding a little bit better that it starts within, maybe, and that we should understand that maybe what we understand as vulnerability is different from my understanding, a little bit different from yours, and therefore our responses will have to be tailored because we understand things differently, and that's kind of okay, I think.
Thank you. I think that's a really good point to leave things on today. Thank you firstly to Estela and to Annie for presenting these findings and for talking us through them. Thank you everybody who has dialed in to join us today. If you joined us not as a member of VAMHN, you can sign up to receive our newsletter as a member, which will give you all of the details about our upcoming events, and also consolidates lots of good resources and events and other opportunities that are happening relevant to violence, abuse and mental health. You can do that from our website. I've also popped in the chat the links to our next 2 webinars where we will be having more fantastic findings and discussions, so please do sign up to join us for those if you haven't done already. Otherwise, you can look out in your inbox over the next few days for the slides and the recording. We'll be getting those to you as soon as we can, and that is all we have time for today. So thank you very much and hope to see you all again soon. Bye.
Thank you.